Okay, everyone, it's currently 7 o'clock, so we should get started. Um, if we could have the first shared slide for me. Thank you. So, hello, everyone, and welcome to the third First Aid On-Site webinar. My name is Sophia Arabu, and I'm joined by my fellow Country Day student and First Aid On-Site board member, Anthony Zong. Today, we'll be discussing safe sex, preventing STDs and unwanted pregnancy. The CDC estimates that there are approximately 20 million new STD infections each year, most of which range from 15 to 24 years of age. 1 in 2 sexually active persons will contract an STI by age 25, so it's a very real problem in America. In addition, 5% of reproductive age women have an unwanted pregnancy. This statistic is significantly higher in the US than in other countries. Today, we are joined by Dr. Monica Rosen, Dr. Anil Kumar, and the Honorable Brian Hartwell. Dr. Rosen is an assistant professor of obstetrics and gynecology at the University of Michigan Medical School. She's received her medical degree from the University of Wisconsin and then completed her residency in obstetrics and gynecology at the University of Michigan. Dr. Anil Kumar is an MD, is a urology specialist in Rochester Hills, and has more than 44 years of experience in the medical field. He's graduated from the University of Mumbai Medical School, and he is the chief of staff of Ascension Province Hospital and is affiliated with Beaumont Hospital, Royal Oak. The Honorable Brian Hartwell is a judge in the 43rd District Court for Hazel Park, Madison Heights, and Ferndale. Previously, he was the mayor and councilman of Madison Heights for 13 years. He has a degree in law from University of Detroit Mercy and a degree in international politics and economics from Western Michigan University. There will be a Q&A at the end of this webinar, and we welcome our first speaker, Dr. Rosen.
Hello, everybody. Thank you so much for that lovely introduction. I'm just going to share my screen here. And give me 1 second. Okay. So I'm going to be talking today about preventing pregnancy and specifically with using effective birth control. I have no disclosures to report. So at the end of my talk, I'm hoping that you will be able to review current birth control methods available, identify long-acting reversible contraceptives as a first-line contraceptive method available for teens, and understand emergency contraceptives or Plan B. This is a slide that talks about the incidence of teenage sexual intercourse, and it describes the percentage of high school students who have ever had sexual intercourse by grade, sex, grade, race, and ethnicity. So you can see that about 38.4% of teens are sexually active. This percentage increases with increasing grade level from 9th to 12th grade, and is slightly higher in males than females, and is similar across Black, Hispanic, and white ethnic groups. This slide indicates the percentage of high school students who were currently sexually active, and you can see here the trend has actually decreased from 1991 to 2019. And then here we have the percentage of high school students who used birth control pills before their last sexual intercourse, again broken down by various categories. And so only 25% of females answered that they used birth control, which is not good. And in 9th grade, only 11.8% of total teenagers, up to 26.7% in 12th grade. So at the last time of sexual intercourse, we have 43% of teens who did not use any type of protection, including a condom. 75% did not use any type of contraceptive birth control, and 20% used drugs or alcohol before they had intercourse. So there are several barriers to why someone may not choose to partake in some type of contraceptive device. The biggest barrier is likely access, so confidentiality in this age group. Teens can't necessarily drive yet, or they don't want their parents to know that they are interested in contraceptives or are sexually active. Also, contraception costs money, and some teens don't have access to money or their own money. There are side effects to some of these medications, including acne and weight gain, which we'll talk about in a minute. Some parents don't agree to allow their child to have birth control because they think that that is therefore permission for them to have sexual intercourse. And so we're going to just go through briefly some of the different methods out there so that you are all familiar with them. So this is a slide that talks about how well birth control works and the different options available. This is all talking about females, I should say. So this top category touches on options that maybe you've heard of, including an IUD, which there are several kinds now, or an intrauterine device, an implant, which is like a little rod that goes in your arm, or obviously getting your tubes tied or sterilization. And all of these are the best kind in that only 1 in 100 women or girls will get pregnant if they have intercourse using one of these methods. The next row we have here is decent. 6 to 9 women will still get pregnant by using only one of these methods, such as the pill, the patch, ring, or a shot. And then the bottom column are methods that are not very good. So 12 to 24 in 100 women will still get pregnant by using a condom, for example. So the first kind of topic I want to go into is our long-acting reversible contraceptives. You can't forget me methods, because once they go inside of you, they just stay there and you don't have to do anything about them. So birth control pills and or condoms are the most commonly used contraceptives, but we know that pills have high failure rates because people forget to take them, especially teenagers, and people don't like the side effects, so they can have high discontinuation rates. LARCs, or long-acting reversible contraception, has low failure rates, so less than 1, as we talked about, less than 1 in 100 women will get pregnant by using a LARC. There's nothing that you need to do. They last for 3 to 10 years, depending on which one you use, and they're very cost effective. There are currently 4 IUDs that are on the market. The American Academy of Pediatrics and the ACOG, which is the National Governing Body of Obstetrics and Gynecology, now considers these first line for teenagers. The primary mechanism of action is that fertilization is prevented by inhibiting sperm motility. And then there are IUDs with hormones in them, and then those without hormones. And the ones with hormones also thicken cervical mucus to prevent sperm from entering into the vagina. So these are just 4 types of the IUDs that are available. This first one is called the Paragard, which is a copper IUD. And I should mention, these are all inserted into the uterus in an office procedure that takes 5 to 10 minutes. And this one here is the most common one that I would say people get, the Mirena IUD, and it lasts for 5 to 7 years. The copper one, or the Paragard IUD, lasts for 7 to 10 years. It does not have any hormone in it, so some like that. But the Mirena also is used for helping with heavy bleeding during periods or cramping with periods, whereas the Paragard sometimes doesn't have those benefits. So the next thing I want to talk about is the implant. This is another method. It looks similar to a matchstick here, and it goes inserted into the arm. It lasts for 3 to 4 years, actually. It's highly effective. It's another 5-minute procedure that you can get in the office, and it is excellent birth control for those who are interested. The biggest side effect would probably be some abnormal bleeding, but most people do quite well with this. So it's another great long-acting option. And I know another topic that we're going to discuss tonight is condom use. some studies show that using the implant or the IUD may decrease the use of condoms. And so I just reiterate here, and I know Dr. Kumar will touch on this later, but condoms are the only way to prevent STIs. Using any of these methods, you can still get a sexually transmitted infection unless you use a condom. So a couple other facts about these long-acting methods. They are 100% reversible, meaning when you take them out, your fertility comes back for those who want to be pregnant. They're over 99% effective. However, right now, and this may be a little higher now, only fewer than 5% of teens on birth control are using these methods, even though they are the #1 methods that are recommended by the American Academy of Pediatrics. The risk of perforation is less than 1 in 1,000, which is when during placement there can be a hole that's poked through the back of the uterus, but it's highly unlikely. And there's a less than 1% risk of a serious complication. So the next kind of category is that second line category that I showed you earlier. And this is talking about the pill, like a birth control pill that I'm sure you've heard of, the NuvaRing and the patch. So as we said, the pill is the most popular form of birth control in teens. It's probably the easiest to get a prescription for. Most people have heard of it. It can be easy for some who take other medications to remember to take a pill every day. But the issue is that the compliance rate is only 44 to 55%. And so if you forget a pill, that can cause you to get pregnant. There's also a high failure rate in teens because of the potential for taking a pill. Most teens miss 3 days per cycle on average. So some methods that we recommend to implement if one did want to be on the pill would be a daily text message that your phone automatically sends you if you have a phone, or keeping a pill by your toothbrush so that you remember when you brush your teeth, you always want to take your pill. The NuvaRing is a ring that looks like this that's inserted into the vagina, and it stays there for a month. And so you don't have to remember to do anything for a month. This gives off a more constant level of hormone into the blood, so you have less breakthrough bleeding. So some people wear it for 3 weeks, some people wear it for 4 weeks, but it's better than doing something every day that you would have to do with the pill. The Ortho Evra patch is a patch you can see here in the orange. It's worn for 7 days and you replace it once a week. So again, it's less frequent that you have to do something than the pill. It's similar hormones to the pill. It can have a high failure rate if you are over almost 200 pounds, but otherwise it can work fairly well. And then the next couple options are, so all of the 3 options, not to get too detailed, that I just talked about have 2 hormones in them, estrogen and progesterone. These next ones only have progesterone in them. The mini pill or progesterone only pill has to be taken at the same time every day, but it's similar to a regular birth control pill. And there can be a high failure rate, so it doesn't necessarily work as good as a regular birth control pill. VTE is a venous thromboembolic event, and so there's less risk of having a blood clot with a progesterone only method than there would be with a method that has estrogen. Depo-Provera, you may have heard of. It's a shot that women or girls can get every 3 months. Some people worry about mood issues or weight gain with this form of contraceptive, but again, it's a pretty good option if you have to go into the doctor 4 times to get a shot, but otherwise, again, you don't have to remember to take something every day, so it's something good for people who desire that. This just says 9 months from now, the only thing I'm expecting to be is more awesome. So plan B for those who are not on birth control and who do have sexual intercourse and are worried that they may be pregnant. There are a few different options that we have available. The first is within 5 days of the last intercourse is to go into a health clinic and have a certain type of IUD placed, which is called a Paragard IUD. This is almost 100% effective at not having you become pregnant. But the downside is that you have to go in and have this placed in the uterus. The next one is called Ella. So it works better if you take it as soon as you can after sexual intercourse, but you can use it up to 5 days. Um, you also have to have a prescription from a doctor or a nurse at a clinic to use this. And then the last one is called Plan B, or Plan B One Step, which most of you I'm sure have heard of. Again, this one works better if you take it right away. You can take this up to 3 days after your unprotected intercourse. You don't need a prescription for this, which is why it's the most accessible. You can just go to a pharmacy and get this off the shelf, pretty much. If you're over 165 pounds, this is less optimal. It may not work as well. And for Ella, if you're over 195 pounds, it may not work as well. Having the power to decide if and when to get pregnant is key. So overall, to summarize, LARCs or long-acting reversible contraception options should be considered first line. They offer superior pregnancy protection and last for a really long time. And remember to think about your ability to be compliant or to do something every day, such as take a pill or remove a patch when you're choosing a method that would work for you. Always use a condom to prevent sexually transmitted infections. These methods only prevent pregnancy, not STIs. And then again, there are several options for emergency contraception if needed, but they all need to be taken within 3 to 5 days. Thank you very much. I'm happy to answer questions now or at the end of the talk.
Thank you, Dr. Rosen, for a very educational presentation on the prevention of unwanted pregnancies and birth control. And I do see a question in the Q&A, but the Q&A session is at the end after all three speakers have gone. So for the questions, I'm going to leave them for the end and after the presentation. And on that note, let's move on to our second speaker, Dr. Kumar, who will be talking about STDs in young adolescents. Dr. Kumar, would you like to take over?
Sure. Thank you very much, Anthony. It really is a great honor. And thank you, Anthony and Sophia, for arranging together with all your other colleagues. It was also very enlightening for me to listen to Dr. Rosen's talk. That was an excellent review of prevention of pregnancy. My talk can be basically summarized in few sentences. Sexuality is very important to the human beings. It is one of the 3 elements that run our lives. It is a chemical directive that few of us can control. When I was growing up in India, we were very conservative and sexuality was not something that we talked about. Being sexual in the adolescent ages was considered taboo, or you were a bad kid. But those things are different. And I think knowing that sexuality is important, it is not that we should tell our kids that sexuality is bad or not to be indulged in, but how do we prevent unnecessary pregnancies? How do we prevent the unnecessary elements that come with sexuality? And that is important. Dr. Rosen has already talked about pregnancy. So that is one element you do not want to have. You're growing up kids with the futures in your horizon, and unnecessary pregnancy can alter that life, which is not just not good for you, but not good for the kid and for society at large. So that's the important thing you have to keep in your mind. The other thing that comes with sexuality, and that's what I'm going to be talking about some, is the sexually transmitted disease. And as Sophia just pointed out, 1 in 2 can be recipients of a sexually transmitted disease. So the important elements of my talk are basically, you have to keep these 2 elements in your thought process all the time. You don't want to be a parent, and you do not want to get sexually transmitted disease, because number 1, there are a lot of diseases that you can get. It's very prevalent. And number 2, which is essential, is a lot of them you cannot get rid of despite the medications that are available. They'll keep recurring back, and they have side effects, and they have long-term consequences. So looking at this kind of existing group of sexually transmitted diseases, we realize that there are some more common than the others. For example, you see the HPV, the commonly talked about venereal warts, are very, very common. Syphilis and others, gonorrhea, um, these are not as prevalent nowadays. In the Middle Ages, syphilis and gonorrhea were very, very common indeed. As a matter of fact, it was so common in France that, and let me just tell you what the side effects or the consequences of gonorrhea was, that men developed urethral stricture disease, which is scarring of the channel where they would pee and they couldn't pee because of the scar tissue. So they used to carry little catheters in their hats, which they had to insert every time they wanted to pass urine. Those times have changed because we have antibiotics now. But you have to remember that once you get these, the consequences still remain. Next slide, please. Also, we have the HIV transmission, which is much, much more common with the other correlated STIs. So again and again, I will keep repeating this one thing. The best way and the only way that we really know how to prevent these infections is by wearing condoms. So adolescent males, make sure you do not have sex without a condom. Do not listen to the conversations that sexuality is not as sensitive with the condom as without. Studies have suggested and shown there is no degree of insensitivity with the condoms as without. And I'll keep repeating this because I want you to go home with only few messages. And one of those greatest messages is condom is very essential if you are having sex. Protected sex is the only way. And luckily, it will prevent both pregnancy and infections. And as far as young ladies, you're concerned, do not have sex with a male partner if they do not have a condom. Because again, as the slides will show you, that a number of infections are asymptomatically held by the females or by the adolescent girls or women because they are asymptomatic, and that gives counter infection to the males if they are not wearing condoms. So it's kind of a ping pong infection. Next slide, please. So clinically, we see two basic descriptions of the presentations of these sexually transmitted diseases. They either present as sores, little ulcerations in different areas, or drips, as we call discharge, either it's a penile discharge or a vaginal discharge. Next, please. Next. So the sores or the ulcers, the essential diseases of sexually transmitted diseases that are concerned with these are syphilis, genital herpes, and the other, which are not as common in the US, are the other three. So syphilis and genital herpes are the essential elements that we see. Next, please. Now, amongst the ones that come with discharges are gonorrhea, chlamydia, and non-gonococcal urethritis. Trichomoniasis in women especially, and the candidiasis, which is really not an STD, but it's very correlated with the STDs. The other, of course, major concerns are genital HPV, especially type 16 and 18, which can be cancerous or oncogenetically cancer producing, especially in women, causing cervical cancers, especially type 16 and 18. Next. Talking about primary syphilis, syphilis is not as common now as was in the older, in the Middle Ages or later, but it's still prevalent in a lot of, including the US, and a lot of the other countries, it's still very prevalent. There is treatment available for it, but a lot of the times it is not recognized and missed. Primary syphilis basically presents only for a short period of time, and it can present as a little ulceration either on the penis or other areas, which lasts for a short while, disappears, and the person may not even realize that they have had primary syphilis, which then leads to the highly infectious part, which it comes up, and that is the secondary syphilis. Next, please. Secondary syphilis can come up with rashes, and this is mostly what one would see. It is characteristic pattern of secondary syphilis, and I had actually, a number of slides, but we didn't want to kind of give you the shock effect of what these diseases can actually do to you. Next, please. Secondary syphilis is also called condyloma lata. Syphilis can affect your arterial little blood vessels, and it can cause numerous forms of diseases in the human body if it's untreated. And it can also lead to what we call as a tertiary syphilis, which can affect the nerves and the brain. So a lot of people used to get pre-dementia. Next slide, please, because of tertiary syphilis. So syphilis is something which has been there for ages. We have to be cognizant of the presentations and, of course, prevention. And I will keep repeating it again and again. Condoms. Please use condoms, because this is the best way of preventing sexually transmitted diseases. So the incidence is, as is reported, this was a report from 2012, and there has been an increase of syphilis. It is more increased in immune compromised people, in HIV cases. So it is definitely there, and we have to be aware of. Penicillin has been a primary treatment for syphilis, but as I said earlier, a lot of them get unrecognized, and that is where the complications of syphilis come in. Next, please. Now again, in between men and women, men, and especially young men, 20 years to 30 years age, are most affected by syphilis. Again, they are most sexually active. There is a very low use of condoms in young adolescents and college students. And that is, again, what we have to realize. Condoms, condoms, condoms. Next slide, please. The other disease that has been very, very clinically prevalent is, of course, herpes. Herpes occurs differently. Your herpes zoster is one. The herpes oral herpes is another. But this is what we have, the sexually transmitted virus of herpes simplex. Next, please. It presents as ulcerations on the penis and the genitalia, and these are painful pustules. So one of the essential elements, if there is any lesion on the genitalia and it is painful with a little vesicle, as we call it, a little pearl-like appearance, then that is syphilis. That is herpes. Herpes is pretty much not curable, is recurrent, and is a lifetime companion for those that get it. So again, prevention of these sexual diseases is the key to your lives, and therefore, as much as sexuality is enjoyable and essential in our lives, please help yourselves by preventing them. Next. In the epidemiology, as you see, the most persons with HSV2 have not received a diagnosis, and that is what transmits the disease further and further. Next. Gonorrhea, as I mentioned earlier, it is again a devastating disease which is associated with a urethral discharge, kind of a whitish, yellowish discharge that's painful. People have a lot of problems passing urine. It's painful urination. I don't know if you guys have seen this movie called Green Mile, and one of the main heroes or main actors gets cured by this guy, but he was actually suffering from gonorrhea. Anyways, dysuria is most common. The long-term consequence of gonorrhea is stricture disease, where the urethra, the channel between the bladder that leads the urine out, gets scarred, and the scar keeps coming back. So you're basically going to have multiple surgeries and difficulties with consequences of back pressure, sometimes kidney failure. Next, please. Next. So in the epidemiology, as you see, there's more than 250,000 cases reported in 2012. There was a downward trend for a long time, and then kind of it plateaued. And it is still very relevant, although in my clinical practice, I do not see as much as I was when I was a medical student. It's slightly higher in females. And again, because in women, it is not as symptomatic. And it is, again, transmitted more easily to the male if there is no protection like a condom used. The other important thing is that you have to realize that a lot of the antimicrobial resistant is becoming prevalent. And so we have to keep looking for new antibiotics that will be very effective. Next, please. Again, by age and sex, it's again young people's disease, and it's pretty much equal, excepting in women it is much more prevalent. And as I mentioned earlier, because it is less symptomatic and therefore more transmissible to the males. So again, young gentlemen, condoms and condoms. Next. I learned some time ago, in order to get a message, I have to repeat it at least 7 times. So if I've passed 7 times with a condom, please let me know, I'll stop. This is the non-gonococcal urethritis. It is also like gonorrhea. It is transmissible sexually. It causes urinary symptoms, and it is fairly prevalent. It's treatable, but again, it is recurrent. Next. Next. So the incidence is very prevalent. As you see, 1.4 million cases reported. Female to male ratio is again 2.4 to 1. The same pathology, that it's less symptomatic in women and therefore more transmitted to the males. Next. Chlamydia, which is another sexually transmitted diseases, is very, very prevalent, more prevalent in women than men. Treatable, but very recurrent. Next. HPV, which is the common warts, as we call them, venereal warts, they have great implication. They have many strains, and one has to be able to know the strains. The strains 16 and 18 are very high risk, not just because they're more transmissible, but they're also carcinogenic, which means they do produce cervical cancer in women. 6 and 11, which are the common ones that you will see in males, which are disfiguring polypoid growths prevalent all over the genitalia that we treat using lasers and other treatments, are not as dangerous as the 16 and 18. And even in men, in women, as I said, cervical cancer, in men, anogenital squamous cell cancers are much more common. Penile cancers were very correlated to the HPV viruses. And there are some theories that prostate cancer, as occurs in the elderly, are also part responsibility of earlier life HP viruses. Next. Next. So low risk types 6 and 11, very prevalent. It does occur most likely around the anogenital areas. The high risk ones, 16 and 18, cervical cancers, very common. Again, as I said, as I tell my patients, those that have the warts, they should not ever have sex without a condom. because again, in the males, the warts will remain in the cells, even though they are not visible as warts, they can be still transmitted to the female, and therefore condoms become the essential element of prevention of any of these HP virus transmissions. Next, please. This is just a slide for between different sexual, for example, the orange is the male sex with male, the male sex with women, and the women, these are the, so you see the MSM, which is male sex with male, has a high degree of genital warts prevalence. Next. So prevention, and then the non-vaccine modalities, again, the condoms become essential, 70% reduction, microbicides and treatment of warts locally, smoking cessation, the smokers have a higher or a lower resistance to recurrence for these warts. Next. Vaccines, there are of course the Cervarix and the Gardasil. In women, these are very effective vaccines and should be definitely taken to prevent these infections. Next slide, please. The Gardasil in males is also very helpful, although the virus is not very virulent if it is the low-grade viruses, but those for the anorectal cancers, etc., prevention is fairly significantly high. Next. This is just basically trying 90% anal cancers can be prevented if the vaccine has been taken. Next. Adolescents and young adults. This is just a little United States occurrence of these diseases. Next, please. So we can look at Michigan and see where we are with chlamydia. We are significantly prevalent in terms of prevalence of chlamydia, especially in women 16 to 24 years age. Next. In men, again, Michigan is high up on the prevalence rate, 16 to 24. Next. Gonorrhea, we are very, again, we are significantly as compared to the rest of the country, a high prevalence for gonorrhea. Next. This is amongst men, equivalent, pretty much not as bad, comparable, and is comparable to the rest of the country. Next. And so that's basically, and I do have a waiver. I do not treat primarily sexually transmitted diseases. I see 2 or 3 in a year, but I did not want to pass this opportunity to talk to young people like you. So if there are any questions, I'd be happy to answer at the time of the question answers. Thank you once again for the opportunity.
Thank you so much, Dr. Kumar, for that educational talk. Next, we'll have the Honorable Judge Hartwell speak.
Hey, thank you, Sophia, and thank you, Anthony, for co-hosting tonight's forum. I'm really happy to be here. Sexuality, it shouldn't have to be scary or confusing or taboo, and I really want to thank Drs. Rosen and Kumar for giving a very clear and coherent message about the science of sexuality. Your presentations educate and empower all of us, children and adults alike. Thank you. Now, I'm a judge in Southeast Oakland County, and every week I handle hundreds of criminal cases, but only about 1% of those criminal cases involve some sort of sexual conduct. Of course, you could probably hear in the news about cases of rape, but there are actually much smaller cases that could still impact people that you may know, something that's less of rape. And one of the important legal concepts that lawyers talk about is the age of consent, and I want to talk about that tonight. But first, a disclaimer, because I'm a judge, I'm not a practicing lawyer anymore, so don't take any of this as legal advice from me. I'm just a judge. If you need legal advice, contact a lawyer, or there's really good legal aid clinics like Lakeshore Legal Aid that can give you free advice, any type of question like this. But I want to talk about the age of consent. The age of consent is really what age can someone consent to have sexual relations? And it really has to do with the power of an adult to manipulate or control a young person. And so the law has to find somewhere on the scale of all ages of where to write that line that people over that age can legally consent to sexual relations, and people under are going to be presumed that they were manipulated into it. So you can think of an adult who's like 30 or 40. They're mature enough to participate in sexual relations, but you could think like a 10-year-old. There's no way that 10-year-old could maturely consent to have sexual relations. But in Michigan, we set the age at 16. So when you turn 16, you have reached the age of consent. But there are still so many shades of gray to that. So your teachers, so even if you're 16, people in power or influence in your life still cannot have sexual relations with you. And you probably see that on the news once or twice a year somewhere in Michigan or America, where a teacher will have relations with their student. And so even in Michigan, even if someone turns 16, their teacher can still not have a sexual relationship with them. And that's just one example of the layers of age of consent. But where this comes into play, the whole concept of age of consent, usually has to come with what we call statutory rape. There's different kinds of rape. One is the rape where it's just forceful, violent. It's a disgusting thing that you would think of maybe in a movie or something. But statutory rape is what age of consent means. So age of consent is 16. So if we're talking about someone under 16, let's say 14-year-old, if someone has sex with that 14-year-old, even if the 14 agrees, we still consider that rape. That's what's called statutory rape. It's someone who's under the age of consent. And so that could be a case that involves teenagers, or maybe someone who had a relationship in high school, but their boyfriend's now in college and now is 20 years old. These are the type of cases that I may see as a judge. So these cases can get pretty life-changing quickly. So if someone has sex with someone who's under 13, that person could go away to jail for life. And the punishment in Michigan gets much more severe the younger the person is involved. And so under 13 is another line we draw in the sand to say, okay, if someone has had sex with that person, it could be 25 years to life in jail. Those are horrific. That's a horrific example. But the other things, the other examples of criminal sexual conduct are less certain. You know, the law is always talking about boyfriends and girlfriends or relationships where someone just goes into college. And so there's that kind of that confusing period of, well, you had a relationship, but now someone is definitely an adult. We can't solve those tonight. So I wanted to talk about more like concrete examples where the law intersects with sexuality, and that hopefully is relatable to some of us. And it has to do with sexting, or sending or creating or sharing a sexually explicit photo or video on your phone, or it could be by email or social media. That's really dangerous. Michigan considers any photograph or any image of someone who's under 18, if it's sexual in nature, to be child pornography. So even two high school students, two 16 or 17-year-olds who are dating and are sharing nude selfies, they could be wrapped into the Michigan child pornography laws, which bring heavy penalties. It's a felony in Michigan. And one, it could just be the possession. So if friends are sending pictures of someone in school, just the possession of it could be 4 years in jail or a $10,000 fine. The person who's spreading sexually explicit messages or pictures or videos, that's called distribution. That's worse. That's 7 years. But the most worse is the person who creates child pornography in the state of Michigan. So even if it could be two high school lovers exchanging pictures, that could be prosecuted as creation of child pornography. And again, that's like a 20-year felony if you're convicted. Now, Michigan doesn't throw young people in jail. Actually, if you're 17 or younger, you're not going to go into the adult criminal system where you would see a judge like me or a circuit judge who's above me. You'll probably be entered into the juvenile justice system. And those judges have full discretion to not just throw you in jail, but to do something that could actually help you. Because of course, if it's just two 16-year-olds sending a picture, that's not as evil and sinister as some creepy adult male in his basement creating something different, right? So there are shades of gray, not just to the law, but to the factual patterns that come into the judicial system. And so the juvenile court system, they have discretion to do things like give you classes or education, or if there is some sort of punishment involved, maybe it's only community service. We treat young people with an understanding that their brains are still developing. And so you're not, inherently dangerous people. You're just maybe confused or misled. And the juvenile court system is a great place for young people to straighten out any issues. Let's see. Oh, one more thing I want to talk about. It's kind of an in transition thing, but if you do get caught up in a criminal case of criminal sexual conduct or creation of child pornography because you sent text messages or pictures, you could possibly fall under the Sex Offender Registration Act. And that's kind of like a stain that could have to follow you for life. Or if you have a criminal record of a sexual conduct case, anywhere you live, you'll have to report to the local police department, hey, I am a former convict under these criminal sexual codes. And that would restrict you even where you could live. You couldn't buy a house or rent an apartment or live in a dorm where there's young people or a park or a school nearby. And so there's, I don't want to scare you. Like the doctor said, sexuality is not taboo. It's something that we need to talk about and be educated and make informed decisions. But I was invited to kind of share the harsher side of sexuality, and that's the criminal justice system. But I'm so happy to be here. Thanks for creating this forum for us to talk. Thank you.
Thank you, Judge Hartwell, for a very informational speech. And now we all know how to stay out of trouble. Thank you. And once again, on behalf of First Aid On Site, I would like to thank Dr. Rosen, Dr. Kumar, and Judge Hartwell for your very excellent speeches today. And that will be the end of our presentation today, folks. And by the way, today's webinar is recorded and will be posted on the website firstaidonsite.org. And feel free to check it out if you have time. And we will now be moving on to our Q&A session. And feel free to ask any questions you have for Dr. Rosen, Dr. Kumar, or Judge Hartwell in the chat. And I believe there are already 3 questions in the chat. So for the first question, why is the IUD the most recommended to teenagers? Is a question from Laurelyn Taylor.
Sure. So the IUD is likely the most recommended because it is something that can be very easily placed in a clinic setting, and the IUD that I typically place can last for 5 to 7 years. So the first thing is that you don't have to remember to take a pill every day. You don't have to remember to get a shot every 3 months. Once you place it in clinic, it's in and you're good with contraception for 5 to 7 years typically. Another thing about the IUD is that there are very, very little risk of side effects. It's the one that is most commonly put in is a hormonal IUD, but there's such little hormone that very little amount of it gets absorbed into your bloodstream. And so you don't necessarily have the acne or the weight gain or the mood issues that you might with the other options available. So it's very well tolerated. It also tends to decrease pain and bleeding with periods, which is an added benefit. So overall, it's a really great option if you can stand the 5 minutes of discomfort potentially of placement.
Thank you for that. Dr. Rosen, I believe this question is also meant for you. Some IUD causes severe overbleeding. Any way to use IOD without overbleeding?
So some girls can have some bleeding or spotting in the first 3 months that can be abnormal. Typically that sort of sorts itself out by 3 to 6 months, and then typically girls will either not have any more periods or have very light periods. Occasionally, in a certain small percentage, there can still be some abnormal bleeding or spotting. I don't know if this is answering the question to whoever asked it. But typically, you know, it's sort of, many of these are a trial and error method, a trial and error, and you just have to see if it would work for you. But for the large majority of girls, it works very well.
Another question in the chat is, this is directed to both of the doctors. Will any STIs cause fertility problems in the future?
I can start that with the males. Yes, the answer is yes, especially gonorrhea. A lot of epididymitis, which is the above the testicle is a little cap which stores the sperm before they are ejaculated out. Those little tubules get scarred, and that leads to infertility. The same thing the gonorrhea does also in women. The fallopian tubes that carry the ovum or the ova, they get scarred, and that's one of the most common cause of infertility. We'll leave it to Dr. Rosen to talk about more about in women what else they might be doing.
Yeah, just like Dr. Kumar said, gonorrhea and also chlamydia in females can travel up through the uterus to the fallopian tubes and often scar the fallopian tubes shut so that an egg cannot meet a sperm to have a pregnancy in the uterus after. You know, not everybody who has chlamydia will have this scarring, but certainly a significant percentage will. And the other thing that it can do is cause abscesses on the fallopian tubes that can also impair fertility.
Thank you for your responses, Dr. Rosen and Dr. Kumar. We have one more question in the Q&A, I believe. It is for Dr. Rosen. The question reads, "It is my understanding that African American women are at higher risk of blood clots and other serious side effects from the birth control pills. What contraceptive outside of condoms do you recommend for women of that ethnic demographic?"
So I think I'll answer this by saying there are several reasons why various women will be at higher risk for blood clots. Not, you know, African American women maybe for certain reasons, and also many other women because of different medical comorbidities. We are always cautious when prescribing birth control pills. Typically, if you have a family history of a blood clotting disorder or some other comorbidity that makes you at higher risk, then we're more likely to not prescribe anything with estrogen. So any of the progesterone-only methods I talked about, which is either a progesterone-only pill, the depot shot, or an implant, or an IUD would all be safer than the methods with estrogen and progesterone combined. But it's hard to make, you know, sort of a general statement without knowing more specifically how someone is at a higher risk.
Thank you for that. We actually have one more question coming in. If any adolescent suspects having an STD, can they get medical treatment without parents' consent or knowledge?
I can take that one. Yes, you can. The way it works at my clinic is if we test most girls or women under the age of 25 for sexually transmitted infections. And we are careful to collect your personal cell phone number or a way to reach you personally, so that if you did have a positive test, we would contact you. And then we can write a prescription a certain way so that only you and your partner can get treated for it. We can also write a prescription for your partner without their medical information.
Okay, thank you, Dr. Rosen. I believe
Anthony, I just want to add to Dr. Rosen's, because she just reminded me by her statement. When one partner is being treated, we have to treat both partners all the time, because that is one of the very important reasons why the infection is transmitted, as we say, a ping pong manner. So that's the most essential. If one partner gets diagnosed, then he or she should always inform the other partner and be treated. Thank you.
And there's one more question in the chat here. It's for Judge Hartwell. If a 19-year-old with a 16-year-old are having consensual sex, are there any problems with being the 19-year-old?
Really good question. I think it would be analyzed looking at the age of consent first. So that both 16 and 19-year-old have reached the age of consent. So they're consenting under the law to engage in sexual activity. But the exception will be, who is the 19-year-old to that person? Does that 19-year-old have any authority, position of authority? Is it a teacher? Is it a summer camp counselor? Is it a foster care worker? You know, a boss? Yeah, any kind of influential position of power over that 16-year-old, then it could be called into question. But based on those facts, it sounds safe. I mean, there may be social or family or other reasons why that we may question that relationship. But by the law, both people have reached the age of consent. I mean, it's different if you separate those just by, if the 16-year-old drops to 15, now there's a problem.
All right, thank you, Judge Hartwell. And I believe that is the last question. So if there are any more questions, you know, you can shoot us an email or go on our website. You can ask your questions there. But I believe that will be it for the Q&A session. And I'd like to thank everyone who attended for coming and watching this webinar. And I would like to thank Judge Hartwell, Dr. Kumar, and Dr. Rosen for speaking today. And yeah, thank you, everyone. Thank you, everyone, for coming today.
Thank you.
Thank you.